Hi, this is Mary Sir, and today we're going to be talking about increasing revenue through billing for nurse work. This is a four-part series because I want all the videos to be very digestible and short, and I'm going to give a little bit of background on this one. I was doing some consulting for a subspecialty group and looking for nurse work and nurse productivity, and just was in awe by the amount of work that I saw between telephone calls and managing things and all of the wonderful things that your nurses are doing. And I know they like to feel valued too. So I think not only is this trying to help add a little bit of revenue for the practice, it's also showing the nurses the value of their work and capturing it as well. So let's get started. Topics in this series include nurse visits and prolonged face-to-face time as part one. Patient education and training is a separate session, part two. Care management codes is in part three, and remote physiologic and therapeutic monitoring is in part four. All four of these are different ways that your nurses not only partner with you to take great care of patients, but they're also all potentially billable. In order to bill for a nurse visit, the supervising physician must be on site in clinic. They do not have to be in the room with the patient or directly supervise, because in that instance, the physician would bill for the patient themselves. Any work the nurse does must be ordered by a physician and must meet incident 2 requirements, meaning they can't see new patients, obviously, can't see new diagnoses or new symptoms. They must follow an already established assessment and plan by another provider, and they must discuss with the provider anything that needs approval. Documentation of the visit must be in the patient record, and the average reimbursement is between $20 and $30 per encounter and has an RVU value for the physician of 0.18. And I know that doesn't sound like a lot, but it's more than just the reimbursement. It's the fact that the nurses feel that their work is valued and captured, as well as the providers. But if a nurse saw 5 patients a week at the Medicare rate, they could add $5,000 to the net revenue for the year. And most of the time, most practices see well more than 5 patients a week from the nurses, so it could be significantly more than that. Couple of clinical examples for when to use CPT 99211 is when the practice has an established patient with an established diagnosis and the physician's already given an assessment and plan of care, but the nurse can review that plan with the physician when the patient presents for something relatively minor. It could be, they have an itchy cast or something like that, and without having to recast, the nurse can take care of that. In addition to that, order procedures within clinical protocols that do not have separately billable codes because they're inclusive of the E&M visit. The E&M, again, in this case being 99211. Things like dressing changes, NG tube changes, PICC line removals, wound care, education and training that has no other CPT code, and other things like that. So just as important as knowing when to bill for it is when not to bill for it. So if the procedure that the nurse is doing does have an appropriate CPT code, like an injection or a vaccine or blood pressure monitoring, we would need to use those codes instead of 99211 because they more accurately describe what the nurse is doing. Secondly, you can't bill for nurse visits in patients who are in a global post-op period, and that is inclusive of procedures like suture removal or dressing changes, things like that, when the provider that they're working with has performed the surgery. If the provider did not perform the surgery, then you can bill for nurses' visits for those kind of things. And then also any previously planned billable procedure on that data service. You would never want to bill 99211 in addition unless they were seen in a different encounter for something completely different than the procedure that was done that day. Even then, it's probably not going to get paid, but you could technically bill it if the diagnosis was significantly different. Here's an example of documentation from a nurse visit, and I would put this on a progress note. With nursing and ancillary notes, they're hard to find, and it's hard to bill off of. So if the patient can be put on the schedule, like on a nurse's schedule or an ad hoc schedule, and then the nurse can fill out a progress note, it's easier to put in the charges for those patients. So you've got a history, you've got an exam, and you've got an assessment and plan, just like a physician note would have. It's also super important to put who the supervising physician is, so that you could look for any ordered procedures. This is another pretty similar example. This patient needed education for how to do her self-administered injections. There are separate codes for education and training with definitive kind of curriculums, but this is more just a nurse teaching a patient how to do those injections and has the same requirements. If your practice has not thought a lot about nurse visit billing or does so in more of a haphazard way, it's nice to do a kickoff meeting. Nurses, again, like to see the value of their work and they like to document well. So you could schedule a kickoff meeting for the nurses and the front desk staff to help them understand how to streamline this process and make it standardized so that all patients are appropriately billed for these services. You can train the front desk staff how to book appointments and tie charges into the EMR. And you can create note templates and training for the nurses, keeping clinic notes separate from telephone encounters or other ancillary notes. If you do that, and your EMR has the capability, you can then pull a report of the progress notes that were written by the nursing staff and audit for billable charges. The second part is just a quick reminder that nursing prolonged services are billable on the same day as a physician E&M service. This is when the nurse has to spend over 30 minutes with the patient face-to-face outside of the time that the physician is doing the level of service. So when and how to bill for nursing prolonged services. Again, the when is during any office visit when the face-to-face nursing time exceeds 30 minutes, not inclusive of the provider time, of course. The nurse must stay with the patient, and it's often used for procedures that are not separately billable, but require the patient to stay in the office with the nurse, like when you're checking for adverse reactions or in-office monitoring post-treatment. How you bill for it, the physician can create an addendum to the clinic note for the day with the nurse's name and the total time spent. Most payers require start and stop times. I know Medicare does, so you could do it that way. And then any feedback from the nurse regarding the patient's status. And then you could bill the add-on codes. So both of these codes are add-on codes to the parent E&M code. You can bill it under the provider's name who performed the E&M. Separately, you could have the nurse write their own note and reference it in the clinic note so that the collectors can find it for appeals. But again, the physician would have to review, sign off on it, and do the billing under their own name. It is billed under the ID of the supervising physician or APP. As always, if there are questions, feel free to shoot us an email, question@m2revenue.com, and we'll have part 2 out hopefully next week. Thanks for watching.